Welcome, everyone. Thanks for joining. Welcome to the National Myeloproliferative Neoplasms Conference. The Leukemia and Lymphoma Society of Canada is proud to introduce our last presentation, Understanding Polycythemia Vera, PV, Diagnosis, Treatments, and Follow-up Care. In this 1-hour live webcast, Dr. Sonia Cerquozzi, hematologist at the Tom Baker Cancer Center, and Peter Lougheed Center in Calgary will review this type of MPN, diagnosis, treatment options, and aspects of follow-up care. Before we begin, let me introduce myself. My name is Desiree Naylor, and I am the Community Service Lead for Alberta here at the Leukemia and Lymphoma Society of Canada. I will be the moderator of this online event. We invite you to type your questions and comments in the Q&A box of your Zoom webinar panel throughout the presentation. An LLSC staff member will monitor the questions, and I will read aloud some of your questions at the end of the presentation. I'd like to remind everyone that due to the large number of participants and limited time, we may not be able to answer all the questions. Please note that Dr. Cerquozzi cannot answer specific questions about a person's health, history, or status. Lastly, today's presentation will be recorded, so you can rewatch it again on our website. As we come together from across Canada, we recognize that we are on the lands of many Indigenous nations. We honor the First Nations, Inuit, and Métis peoples whose deep connection to these lands enrich our community. We value Indigenous voices and are working to ensure they are truly represented in our leadership and staff. At the Leukemia and Lymphoma Society of Canada, our commitment to diversity, inclusion, belonging, and health equity guides how we work to support and uplift everyone affected by blood cancers. Are you looking for specific programs or resources but not sure where to find them? We are here to help. You can connect with the community service lead in your area to receive personalized assistance and get connected to resources in your area. We can listen attentively and with compassion to the challenges you are facing, point you to information specific to your type of blood cancer or treatment, help you get organized to manage and take charge of your care, and identify services that would be beneficial to you. We know that having a diagnosis of polycythemia vera can be overwhelming, but know that you are not alone. There is a blood cancer community that is here to support you every step of the way. As mentioned earlier, you can access one-on-one support to help you navigate the blood cancer experience. On our website, you will find tailored information and resources, including those specific to PV. Our goal is to better serve the community and offer an improved experience. The information and resources on our website are tailored and presented in multimedia formats to address the variety of needs and preferences. This includes fact sheets and booklets, like the one you see on your screen, podcasts from our channel, The Blood Cancer Experience. You can find hundreds of podcasts for people touched by a blood cancer and many addressing challenges that people living with PV face. We speak to experts about current topics such as treatments, diagnosis, and research. You will also hear personal stories from people touched by blood cancer. We have information resources to watch, like previous webcasts and animated videos. To find, you can visit bloodcancers.ca to read, listen, and watch all of these great resources. Before introducing our speaker, we wanted to address an important situation for the MPN community, the Pegasys shortage. And to do that, we have invited Dr. Sonia Cerquozzi, hematologist at the Jewish General Hospital Montreal and president of the Canadian MPN group, to address this in this short video. If you have any questions related to this situation, please contact your doctor, the LLSC, or the Canadian MPN group.
Hi everyone, I'm Dr. Sonia Cerquozzi. I'm president of the Canadian MPN group. I'm a hematologist and an MPN specialist at the Jewish General Hospital in Montreal, Canada. I know that the Pegasys shortage has been incredibly stressful, and I want to start by recognizing the strength of this community, both patients and physicians, who have come together to advocate for a solution. Your voices have been powerful, and I sincerely thank you for your patience and your persistence. Because of our collective effort, Health Canada has taken an unprecedented step. For the first time, they have approved an exceptional importation of Ropeg, which is not a Health Canada approved drug. This is in response to patient and physician advocacy. This decision reflects the impact of a united front, patient, physician, and pharma, working together to ensure continued access to treatment. We have been working on several next steps to help navigate this transition. Some remaining Pegasys supply, approximately 60%, is still available and is being redistributed across provinces to ensure fair access. A guidance letter has been prepared to help physicians make informed decisions on Pegasys use. Meetings with provincial authorities are planned to determine how ROPEG will be reimbursed and distributed, and we expect updates shortly. We will then issue a guidance document addressing the safest way to transition patients from Pegasys to ROPEG. I also want to take a moment to acknowledge the dedication of my colleague physicians across the country. Many of you have gone above and beyond, advocating for patients, adapting to challenges, and working through uncertainty. This progress would not have been possible without your efforts. I also want to thank Forest Health for their critical support in ensuring a rapid supply chain of ROPEG and for helping amplify our advocacy. There is still work ahead, but we are making progress. Thank you for your trust, your patience, and your continued advocacy.
It is now time to introduce today's speaker, Dr. Sonia Cerquozzi. Dr. Cerquozzi is a clinical assistant professor at the University of Calgary. She completed her internal medicine and hematology training at the University of Calgary in 2015. She proceeded to an advanced hematology fellowship in myeloid disorders at the Mayo Clinic in Rochester, Minnesota, with a clinical and research focus in myeloproliferative neoplasms. She has been at the University of Calgary since January 2017 and has a myeloid malignancy practice at both the Tom Baker Cancer Center and Peter Lougheed Center with clinical and research interests in MPNs, including rare disorders such as systematic mastocytosis. Thank you so much for being with us today, Dr. Cerquozzi.
Thank you, Desiree. Thank you, Pascal. Thank you to the Leukemia Lymphoma Society for allowing me to talk today and review the topic of polycythemia vera, the diagnosis, treatments, and follow-up. My objectives are to review what polycythemia vera is, discuss how PV is diagnosed, what the current available treatments are for PV, and what is important to your follow-up and PV care. These are my disclosures based on grants, speaking, and consultancy fees. So polycythemia vera, which I'll refer to as PV in short, is a disorder of the bone marrow in which we make increased blood cells, and specifically we speak of myeloid lineage or myeloid cells, and we think of this as mainly the elevation of red blood cells. However, it's an overproduction of the bone marrow that can lead to other myeloid cell lines increasing, such as our platelets as well as our white blood cells. This is a subtype of a myeloproliferative neoplasm, or MPN, which is chronic and includes other subtypes that we discuss in this slide with Dr. Gupta, in other slides shows with Dr. Gupta and Dr. Linda Foltz being ET and myelofibrosis of other subtypes of MPN. We know polycythemia vera can evolve. It is a chronic blood cancer that can also evolve to chronic disorder of myelofibrosis, or in rare instances into acute myeloid leukemia. The median age at which people present tends to be in 65, but there are 10% of patients who present at 40 years old or younger. And when we think of the new cases or incidence of PV, it tends to be about 1 to 3 people per 100,000, with slightly higher increase in men versus female. And general cases or prevalence, we might see 22 cases of PV per 100,000 patient population. When we think of the cause for polycythemia vera, this was discovered in the 2000s to be from a mutation in a JAK2 protein that's intracellular and involved in cell signaling. This specific mutation is JAK2 V617F mutation, which we can test from the peripheral blood. It's present in the majority of patients with polycythemia vera, where patients may have this specific JAK2 mutation in 95% of cases, or a variant with a different gene section altered in exon 12 in 4 to 5% cases. And so normally our stem cells require some signal from our body that we need to produce more cells, and this is regulated. In the setting of RBCs, or red blood cell production, normally low levels or low oxygen sensing can signal for the protein erythropoietin to bind to a cell receptor, activate JAK2, and lead to the ongoing JAK-STAT signaling pathway, which will activate genes within the nucleus of a cell to make more cells. In the setting of a JAK2 mutation, this mutation means that this is activation irrespective without required signaling that leads to dysregulation and excess blood cell production. When we look at the diagnosis of polycythemia vera, it involves, again, specific criteria. And normally, what we speak of is the criteria of elevated red cells or elevated hemoglobin. Hemoglobin being the component within red cells that carry oxygen, and hematocrit being represented here as the component of concentration of red cells. So if we were spinning our blood samples down, we would have a larger portion being hematocrit, about 45 to 50%, with variation depending on gender, and then a buffy coat of white cells or platelets, and then plasma. For a diagnosis, we generally will say hemoglobin above 165 in males or 160 in females will lead us to assess, as well as elevations in hematocrit of 49% or 48% respectively. As mentioned, we expect to see changes within the bone marrow, where there will be patients that may have a bone marrow biopsy that will show hypercellular or active trilineage growth, meaning all cell lines of the white cells, platelets, and red cells will be elevated with characteristic features in megakaryocytes, which are stem cells of the platelets. And then again, as mentioned, this JAK2 V617F or alternative JAK mutation is seen. Most patients can meet these three major criteria, but we may avoid doing bone marrow biopsies and diagnosis in select cases where patients have higher hemoglobin levels and have the presence of the high hemoglobin and hematocrit, JAK2, as well as this low EPO level. As I had mentioned, we depend on EPO to signal to our bone marrow for cells. And in the case of polycythemia vera, where a bone marrow is hyperactive, there's no signaling required. And one will assess and see an EPO level that is often low, and that would be also one of the minor criteria in diagnosis. When we speak of the practical diagnostic management of polycythemia vera, we can see that we often will do JAK2 mutation and EPO levels at screening. Patients, again, who are positive, we would know that they have a myeloproliferative neoplasm and look for other criteria. If patients are negative, then we may then be following up to ensure we have low EPO levels, and again, potentially screening for other exon mutations. Most can be done from the bone marrow, but we do try to do some peripheral blood specific testing if possible. And if patients have lack of the features of the JAK2 mutation, again, a bone marrow biopsy looking for characteristic findings can be performed. In cases where patients have high EPO levels, we're often considering that this may be a driven elevation in hemoglobin and hematocrit due to other factors not related to a bone marrow disorder. So basic investigations often through your family doctor will involve looking at history of symptoms, splenomegaly or large spleen, and history of blood clots. And often we'll be looking at a spleen on examination as well as the blood work in a series of blood tests and look for other features of iron studies or ferritin, which is a part of the iron studies, as well as baseline kidney, liver tests, and again, that erythropoietin level. Signs and symptoms of polycythemia can be quite variable, but generally speaking, a lot of symptoms may be related to hyperviscosity or thickening of the blood. As I had shown when we spun down that red cells, the higher that red cell concentration, the thicker the blood and harder it is to move through small blood vessels or even large blood vessels at times. Patients can present with reddening of their face or what we call facial plethora. Again, they may present with a lot of red cells that are turning over quickly and spilling uric acid, and that can lead to gout with uric acid accumulation at the joints. Patients may have splenomegaly, so enlarged spleen, again in 30-40% of cases, and in some cases, patients may have an associated enlarged liver. And more commonly, we see risks of blood clots in patients. And certainly, this is an example of a patient who has an enlarged reddened left leg that is related to a deep vein thrombosis or clot in the lower leg. Other common symptoms can sometimes be related to generalized symptoms that are often hard to explain, but patients often have complaints of problems with fatigue, concentration, often will have some nonspecific dizziness, and sometimes have headaches. A lot of these, again, are related to the fact that patients have that slow blood flow and lower oxygen perfusion in small blood vessels. Bleeding can happen if patients have high platelet counts. And a very characteristic question you may be asked is burning in your hands and feet with warm water exposure or generalized body itching with warm water exposure known as aquagenic pruritus. When we ask patients about their symptoms and large international surveys have been performed, unfortunately, the majority of patients, 90%, have related symptoms, irrespective if they have low risk or not. Patients often, 50%, have fatigue. Symptoms, again, are a variety, and you could see the three MPN types here, with PV being the medium blue hint. But again, 20% or more symptoms are often across categories, and it impacts patients' quality of life. Maybe not everyone feels their physician understands their symptoms to the extent that they're experiencing, or they're concerned about the hardships, physical, emotional, and financial, their chronic disease will have. Our treatment goals are always to improve symptoms and treat these symptoms through various medications I'll discuss. The biggest factor in terms of mortality and rates of significant decline in health and death are related to thromboembolic or blood clots. And so a general population may experience less than 1%. General patients may experience less than 1% risk of blood clot per year, versus those with PV in orange. You may see a variety of percentage quoted, often 2 to 3% incidence of thrombosis or blood clots per year. And so we certainly want to minimize these, which can be potentially life-threatening events. We always aim with all of our treatments to have ways to prevent transformation. This is still a work in progress, as I'll discuss. More evidence is coming towards potential disease modification. But there is no formal treatment that we would say is curative, particularly aimed at polycythemia vera. Our treatment guidelines are based on international guidelines, and they include the European Society of Medical Oncology, our National Comprehensive Cancer Network, NCCN, that's used in the US. Our main goal is to divide patients based on their risk of blood clots, and low risk would be patients who are less than 60 and have had no prior blood clot. And these patients are treated with what we call phlebotomy or bloodletting. As well as low-dose aspirin, which here we use is 81 milligrams daily. Patients who are high risk are those that, as a result, have had a blood clot in the past, as well as those that are aged 60 or over. And this higher risk is the concern that patients will develop higher risk of blood clots, and they may still be treated with phlebotomies and low-dose aspirin or an alternative blood thinner if they've had a clot before. But in addition, we talk about cytoreduction or therapies to lower the lower the blood counts, and that includes hydroxyurea, or as discussed with Dr. Sharhan, forms of interferon. Previously, we have been using Pegasys, known as pegylated interferon alpha 2A. This is the current shortage we've discussed, and current newer agents that are available hopefully soon will be the Ropeg or Besremi. Second-line treatments I'll review as well include clinical trial in always settings, as well as ruxolitinib or using an alternative first line in a lot of settings. When we look at thrombosis and polycythemia vera, there's always numerous factors. I've mentioned age and prior clot history. Other risks are those that we worry about in terms of cardiovascular disease. So patients with high blood pressure, diabetes, obesity are at high risk, or those that smoke. The JAK2 mutation in itself increases the risk of blood clots. And then there's various cellular factors that, with additional activation of white cells or inflammatory processes or higher platelet levels, and the various communication cells, numerous factors together accumulate one's risk. There's different types of blood clots or thrombosis. Those that are in the arteries or arterial clots like heart attacks, or myocardial infarctions, strokes or mini strokes like TIAs, and peripheral vascular disease in the lower legs. Clots in the venous system are those that's shown in that previous picture: deep vein thrombosis, pulmonary embolism, a vein clot in the lungs, or patients may have venous clots in superficial veins like those that we use IVs for, or those that involve the liver and spleen, such as portal vein thrombosis or brain cerebral vein thrombosis. Oftentimes, again, because of sludging and slow blood flow in small capillaries or arteries, patients may have microcirculatory thrombi, and that can lead to the burning hand sensation feeling described as erythromelalgia, or various headaches, dizziness, as well as transient vision changes, or a specifically retinal vein occlusion like amaurosis fugax. The importance of low-dose aspirin was described very early on in the ECLAP study. So a large observational cohort of patients, and specifically looking at low-risk patients, 500 patients were assessed to compare to aspirin versus a sugar pill or placebo. And what we see here is the higher purple line represents that patients on aspirin had a probability of more event-free survival of not having events in combination that were looked at together, such as strokes, heart attacks, and death related to cardiac events or significant blood clots such as PE or DVT. This shows that implementing aspirin can reduce the risk of thrombosis or blood clots at least twofold. And so low-dose aspirin, again, along with phlebotomies or bloodletting, is a standard that is used. And the advantage, certainly, of phlebotomies is it reduces our counts immediately by removing our red cells. It can be done as an outpatient, is often well tolerated, aside from the significant symptoms of having your blood volume depleted, which is often treated with hydration or fluids. How we know what level to target has been classically maintaining that hematocrit or thickness or viscosity of the blood low at a level of hematocrit of less than 45%. This was confirmed with the study, the CytoPV, that was presented and published in 2013. And what was found is they divided patients into a low hematocrit group, as shown in green, or a high hematocrit group. And a low hematocrit group maintained level of hematocrit of less than 45%, which is compared to the high level where patients were maintained between a hematocrit of 45 to 50%. In both of these instances, you can see a significant, again, event-free improvement and reduction of thrombotic events, whether these were cardiovascular and major events combined or total cardiovascular events, where those patients with the low hematocrit group had better outcomes with less hematocrit, and there was a lower hematocrits, and there is a 75% reduction in thrombosis in those with the low hematocrit group, and patients here were maintained to that low hematocrit through a combination of phlebotomy or other cytoreduction. And so we use this important staple of hematocrit less than 45% for patients with PV. Phlebotomy does come with some complications. Again, we often offer this for low-dose PV patients, but the disadvantage is it can sometimes be inconvenient for patients to attend outpatient appointments. It certainly has improvements in reducing hematocrit, and it will remove the red blood cells and iron stores. And the risk of removing iron is patients often then can have complications related to iron deficiency, related to hair loss, thinning, brittle nails, cold intolerance, restless legs, or changes in the mouth or tongue, and symptoms that are not pleasurable at all times and can be quite effective to quality of life. And certainly phlebotomies aren't able to reduce that a level of platelet, but rather patients can have elevations in platelets when they get iron deficient, and white cells aren't reduced through phlebotomy. And so, aside from maintaining a hematocrit less than 45%, there are specific guidelines the European Leukemia Network has indicated to attain complete response in PV. And that means trying to maintain a white blood count less than 10, a hematocrit less than 45% without any phlebotomies for 3 months, and to maintain platelet levels within normal range less than 400 and a normal spleen size. What are warning signs? Certainly having white count elevations, patients needing a lot of phlebotomies, and maintain patients still having persistent symptoms or problems with spleen related symptoms. And so there has been evidence showing the importance of phlebotomies, and that perhaps patients having frequent phlebotomies tells us that they still have higher risk of thrombosis or again clotting events. Patients getting 3 or more phlebotomies per year had higher rates of thrombosis, which was statistically significant compared to those without. And this is likely because patients aren't maintaining that steady state of maintaining their hematocrit levels less than those target of 45%. Recently, more publications have tried to confirm what are the risks in terms of blood clotting. And again, a study recently published had shown in a prospective manner of looking at PV patients in the United States. Over 2,000 were assessed, in which case 142 thrombotic events were observed among over 100 patients. And patients were followed for a duration up to 3 years. And again, what we can see in this bar graph showing the hazard ratio or risk of these factors being more worrisome to cause thrombosis, with one being not a factor or not conclusive to having influence. We again see in the above line that patients with a level of hematocrit above 45% have a higher rate of thrombosis, and even higher so patients with an elevated white count of greater than 11 have over a twofold increased risk. And other factors were looked at this study, and they looking at factors at the time of someone's blood clot, or here in B in this below section, looking at factors when they're sustained and persistent for over a year. And although platelet count may have had a mild influence, again, the same features of high white count, hematocrit, and specifically neutrophils or high white cells, along with a history of thrombosis, continue to be consistent factors. Perhaps platelets here, as they cross that midline, did not seem to be a consistent factor, and a hazard ratio which was lower. And so perhaps what we can gather from this information is that the persistence uh, of a lower of a high hematocrit or persistence of high white count and having a history of thrombosis are important factors. And certainly sometimes with high platelets, these haven't been substantially shown in data for polycythemia as being a factor that is consistent, that is something that we need to cytoreduce for at all times. Hydroxyurea is one of the most common cytoreductive therapies used for a long time in first line to reduce blood counts. And as I pointed out, we use cytoreduction in high-risk polycythemia vera. What's been found in large retrospective studies looking back at patient populations of over 800, hydroxyurea has improved survival compared to patients that were not using this mode of cytoreduction, and risks of thrombosis were lower in patients from risk of thrombosis of 20 or close to 30% versus 45% in long-term studies. And retrospective studies of, again, patients over 30 years being assessed have shown reduced cardiovascular events or blood clots in patients with use of hydroxyurea. Hydroxyurea is an oral medication that can be dosed at 15 to 20 milligram per kilogram. It's provided daily in tablet form and is quite effective and often well tolerated, but it will lead to low blood counts as it's intended to lower hematocrit. We watch for too low blood counts and maintain those counts within stable levels. Patients can have oral mouth sores, get upset stomach, and nausea or vomiting. There's a risk in some 15 to 20% of patients of fevers, and And certainly, as shown here, patients can get deep leg ulcers, which can be quite hard, and poor wound healing has been noted with hydroxyurea. And fevers and leg ulcers certainly are indications to stop therapy and consider alternatives. Patients also have features of changes in darkening in their nails or thinning of the hair. And another risk we commonly see is risks of non-melanoma skin cancer like basal cell or squamous cell carcinoma. Interferon alpha, as discussed earlier, is also a first-line treatment in polycythemia vera and has continued to have ongoing development. It works through more immune modification, and it's been shown with original interferon usage and now more data I'll present in reducing symptoms of patients, reducing the risk of thrombosis as we've seen with hydroxyurea, also achieving complete hematologic response with overall response rates and control of hematocrit in over 80% of patients, and complete hematologic response, as mentioned, with other modification of spleen and additional blood work in 49%. I think what's becoming more of importance in evaluation in research and newer studies now is the assessment of JAK2 V617F allelic burden. And that mutation, again, can be quantified in terms of how much of the mutation is present. And patients can have what we call complete molecular response and reduction of this allelic burden to quite drastic levels. And this complete molecular response is a thought of how we can potentially have more disease modifying therapy. And with more modification, one would hope we can potentially have lasting effects of a drug with potential discontinuation. The major issue that's always been the factor in terms of pegylated interferon, is its intolerance. And so variations and modifications pharmaceutically have been derived, like pegylated interferon, that have allowed for less frequent dosing, as well as more improved tolerability. And that's because even within PV and ET, we can see up to 25, even up to 30% discontinuations of interferon. Serious side effects can be exacerbations of autoimmune disease, neuropathy, hypothyroidism, inflammation of the retina or retinitis, and various psychiatric disturbances can arise. ROPEG is a further modification of Pegasys in which this can be offered as an injection provided subcutaneously on a Q2-week basis. The PROUD PV and continuation PV studies were large studies involving patients with polycythemia vera that either had not had prior treatment or had prior treatment with hydroxyurea not achieving response. And patients were compared and stratified to continue with hydroxyurea or ROPEG and were followed then for up to 5 years in the continuation study. The biggest feature in this study that we see is the long-term effects. And as we can see initially with these curves with ROPEG in blue, is that molecular response may not initially occur, but after 18 months, there's significant improvement with responses and reductions in the JAK2 allelic burden with up to 60, so close to 70% of patients responding. However, those in the control arm using hydroxyurea mainly can see that potentially there's this loss of this allelic control. And again, the hydroxyurea was never formally expected to have this molecular response. And these are quite sustained. And again, similar studies have shown again in control in gray that the median JAK allele burden may potentially increase with time versus that in red with ROPEG continues to decrease up to 6 years or more. We can see these improvements. And both in ET or here in PV in the blue bars, we can see that there's significant improvements in patient symptoms, their total symptom score, fatigue, dizziness, numbness, weight loss. And although we still see with ROPEG, there's still side effects that we need to be aware of where patients can still experience flu-like symptoms with injections or irritation at sites. And there's still potential visual side effects such as blurring or changing of visions that patients do experience with ROPEG. When looking at thrombosis, again, the initial proud PV and continuation PV have had a signal that there was a reduction in major cardiovascular events and compared to the control arm. Major thrombotic events overall were very similar. And I think we continue to look for long data for these rare events that can happen in this chronic disease. Hydroxyurea, as I've mentioned, is an option, but there could be resistance or intolerance, and this can be still found in about 20% of patients. There is specific definition for physicians to assess what is hydroxyurea resistance in terms of patients still needing phlebotomies to maintain their hematocrit less than 45%, patients having uncontrolled other cell line elevations, or unable to reduce their spleen size effectively, or unable to relieve symptoms. And often we trial patients on doses up to 2.5 gram per day and assess how we can improve symptoms for a period of 3 months or slightly more. But this is defined as persistent, tolerable maximum dose for 3 months. Similarly, patients may have intolerance where they're unable to tolerate due to the blood counts dropping, such as neutrophils or platelets, or again, those leg ulcerations or significant toxicity with mouth or sores, or persistent fevers or inflammation of the lung. And we know resistance is of importance as resistance lead patients to having higher risk of progression to AML, and that can certainly affect survival. And again, we can see resistance in about 15 to 20% of patients with PV. And so alternative second-line agents for patients with resistance or intolerance do exist. The JAK inhibitor, this JAK1/2 inhibitor known as Jakafi or ruxolitinib, is available in Canada as second-line agent in the setting of hydroxyurea-resistant or intolerant PV. It is offered as an oral therapy that's dosed 10 to 25 milligrams by mouth twice a day. And ruxolitinib has been shown in various studies, particularly we call these studies response and response 2, where they randomized and looked at patients who had hydroxyurea intolerance or resistance and compared them to best available therapy, which may have included ongoing hydroxyurea or interferon in about 15% of patients. And they looked at control of hematocrit, and ruxolitinib control was quite good at 62% achieving control compared to 18 in patients at week 28. And this was sustained at a long term with close to 50% of patients maintaining hematocrit control. And again, a reduction in their significant symptoms was higher with ruxolitinib. And as I showed with interferon, the molecular response exists as well with ruxolitinib. Patients were allowed to cross over, and this is those green population. We can see that a reduction here of 50% or more of that allelic burden was found still in close to 40% of patients, even those that crossed over. And the duration of response, and being able to have that complete response and normalization of counts, again, was more significant in patients getting ruxolitinib versus best available and was had been maintained for a longer duration. And again, we can see that molecular response was shown in this MAGIC PV study done recently. There was good evidence to again show the consistent reduction, but this was a study where they're actually able to show the influence in that patients who were able to attain a molecular response, as shown here in purple, and maintain a JAK2 allelic reduction of 50% or more, had better event-free survival. And event-free survival here was defined as a combination of patients having blood clots, bleeding, transformation, or death. So this is one of the first studies that actually was able to correlate the importance of that molecular response with the overall survival of patients, and again, reduction of thrombosis as well. When we look at the blood clot history, blood clot risk again, ruxolitinib has shown in both the response studies to reduce rates of blood clots, even in those patients who crossed over, with the highest rate experienced in those who remained on best available therapy. And Spanish registry, looking back at retrospective data rather than direct clinical trial, also showed the same. In particular, the arterial thrombosis risks were reduced with ruxolitinib. The side effects of ruxolitinib again exist, risks of lowering blood clots, which is our goal, but not doing so to an extreme. Risks of infections, in particular, of risk here with tuberculosis reactivation, herpes zoster or shingles, or hepatitis B being serious infections that patients may be at risk of and often require screening. Patients gain weight and have higher cholesterol levels with the use of ruxolitinib, and again, those non-melanoma skin cancers as described with hydroxyurea occur with these JAK inhibitors, and upset stomachs such as nausea or vomiting occur. And so patients are often screened for various infections, are suggested to be on an antiviral or have a shingles vaccine, and also often we're assessing lipids or cholesterol levels on a routine basis. The progression to PV of PV to AML or myelofibrosis, as I mentioned, exists in which we may see progression over decades, but there's been various quotes of probability of progression may occur over a period of 10 years, for example, 10%. Patients can also directly transform to acute myeloid leukemia without having had a transformation to myelofibrosis, although very rare over decades. What we can see as signs for myelofibrosis that may occur is the development of patients having low blood counts or being very sensitive or requiring lowering doses of their cytoreduction. Patients may have high white blood counts or specific changes where we see more immature cells such as nucleated red cells or blasts, and they may experience more enlargement of their spleen if there's increased spleen fibrosis or scarring, and higher levels of inflammatory markers such as LDH, as well as the development of constitutional symptoms, which we define as drenching night sweats, weight loss, or fevers. So, what is important in your follow up care is always being an advocate. I think everyone attending here is advocating for their own care by attending and informing themselves more about their condition. So, it's important to continue to learn about your condition and schedule ongoing follow up with your physician, partnering up to assess how you can understand more about your disease is always of importance, and getting support through networks like the Leukemia Lymphoma Society. When you're assessing your treatments, it's important to look at options of what alternatives may exist, but normal routine blood work where you'll be talking to your physician about assessing your hematocrit levels and maintaining those goals is important that you're meeting those treatment targets. Again, with the hematocrit white blood count being of particular interest, and reviewing signs and symptoms related to how you're feeling and providing that information routinely to your physician. You may be able to track your symptoms through an MPN tracker or a means that can be downloaded through Apple or Google Play and available to you routinely and electronically. And it's important on exam and patients being assessed to assess if they can have a palpable spleen on exam, as well as looking at routine assessment of patients' risks for blood clots. So it's important to have ongoing follow-up with your family physician and maintain your control of your diabetes and sugars, lipids, blood pressure, and assessing weight and reducing those risk factors. That means having a healthy lifestyle and doing regular activity, which often also has been shown to improve patients' overall symptoms that are including fatigue. PV research continues to develop, and I think the big components of ongoing research involves understanding the importance of the molecular response and what it ultimately means and how it ultimately affects a patient's course. And so, again, I've shown some more data that is existing, and various studies are still in progress with BESREMI or ROPEG, in which evaluation of molecular response is being assessed, and long-term studies and evaluations are continuing, along with, again, the ruxolitinib data that's continuing to assess molecular response. Newer agents may be agents that affect the iron metabolism or control on that. One common agent that's being discussed in clinical trial and more advanced may be resveratrol. HiDAC inhibitors such as Jinvestat may be also in studies, and there's certainly other clinical trials ongoing. In particular, when looking at resveratrol, which is often discussed, it is a hepcidin mimetic or pretend hepcidin, one would say. And hepcidin is important as it regulates or blocks the ferropoietin that makes iron available in the process of allowing red cells to continue to develop. Red cells require iron for growth, and so this type of resveratrol is a way that we can block through this kind of hepcidin mechanism is blocking the export and availability of iron, so there's less production of red cells. My summaries, I hope, been able to clear some information for everyone today and present the importance of polycythemia and understanding it is a chronic blood cancer that belongs to a group of myeloproliferative neoplasms. It's driven again by the JAK2 mutation and results in elevated blood counts, as this results in blood clotting because of the hyperviscosity. Patients are treated with low-dose aspirin, and the importance of controlling hematocrit less than 45% was outlined, as well as white blood cell control being an important factor. Cytoreduction options, as I reviewed, are hydroxyurea and interferon-based therapy, with second-line agent being ruxolitinib that is available. It's important to modify your lifetime risk factors for blood clots and routine follow-up and monitoring of your counts and symptoms, and controlling blood clot risks and assessing for your progression through routine checkups. I want to thank everyone and for listening, and again, the Leukemia Lymphoma Society for allowing me to talk today.
Thank you so much, Dr. Cerquozzi. We appreciate you being with us and sharing your expertise and insights. That was a lot of great information. What we're going to do now is our question and answer period. So if you haven't already done so, be sure to use the Q&A box in the Zoom webinar panel at the very bottom of your screen to type your questions. As we mentioned earlier, due to the large number of participants and limited time, we may not be able to answer all of the questions. And again, also note that Dr. Cerquozzi cannot answer specific questions about a person's health history or status. So I do see there are a couple of questions that are coming in. So the first one, you kind of talked about it here at the end. Do you have any idea with some of the newer treatments that are in clinical trial when they might be approved and available in Canada?
Um, Unfortunately, I wouldn't be able to speak too much to the um, specific clinical trials timeline. We often work as a Canadian MPN group in order to provide clinical trials to our patients and may discuss. Given the rarity of MPNs, there may be times they're not always available in all cities. And so this is very specific. To everyone's particular site and academic center. So it's an important question to again review with your own local hematologist, as it is very specific to each site, what trials are going to be offered and available and the timelines to accessing those sites at each site hospital.
Wonderful, thank you. Another question is with interferon, it's used to treat chronic viral illnesses such as hepatitis B and C. Could MPN be caused by the activation of a latent virus?
I think that's a great question. I think we ultimately don't really fully understand how that mechanism of JAK2 became mutated. Certainly, there's always a question of whether some form of inflammation and cell stress triggered a change to allow for the cell to have this replication. We have more data that shows that perhaps the JAK2 mutation quite develops early, and it's just that that mutation may exist at patients quite a young age. However, the actual activation and upregulation of it may be much later in life, given the median age. I don't think there's any specific evidence linking particular virus to MPNs. We may see certain viruses trigger, the potential of particular lymphomas, but not in the setting of MPNs.
Wonderful. Have there been studies comparing the rate of transformation to MF by treatment? So whether you're taking, the interferon or a phlebotomy, like any of those that kind of talk about that transformation.
No, I think again, tried to highlight that we are starting to see those studies. And I think again, the study with Magic PV with ruxolitinib with Dr. Harrison attempted to establish those endpoints of event-free survival, looking at again that potential of transformation being included in that factor. I think again, looking at our more specific studies with Ropeg or Bezremi, those outcomes are what we're hoping to evaluate with long-term evaluation of patients. But there hasn't been an easy way to study this thus far in past studies yet.
Wonderful. Um, if patients might develop the JAK2 mutations earlier in age, should there be more screening to detect it?
That's a good question. I think the issue is it can be that we may see patients have a JAK2 mutation with no blood abnormalities as well. It can be picked up incidentally. We do assess patients who come in with an unusual or atypical clot with no risk factors and may find a JAK2 mutation for which there is no abnormalities of the blood levels yet. And in that setting, if patients have normal blood counts and hematocrit, for example, they would be monitored without active treatment. So as of now, we don't have, indication that generalized screening of JAK2 is indicated or would provide us with knowledge that we could provide to patients, their expectations for their future or if this will be a pathologic problem for them.
And I did want to answer this question because I think this is always an important one, but does the chronic nature of this type of blood cancer create the need for more dedicated strategies to address ongoing fatigue? And what are maybe some helpful solutions or ideas to help with that?
Yeah, and as I mentioned in that landmark study, I think there is even kind of a discrepancy what we as physicians think people are experiencing versus what patients are experiencing and the depth and amount of quality of life affected. And I think more data is showing too that young patients presenting with MPNs do have a significant amount of symptoms and issues with fatigue and quality of life. Unfortunately, there isn't one specific drug that we've found that may alleviate particularly the fatigue. Certainly, I think ruxolitinib has shown a lot of symptom improvements. We do see, though there's maybe flu-like illness in general as malaise with interferons or Bezremi. Again, I had shown that those symptoms do improve. I think when we speak about, other methods, there has been data from the Mayo Clinic with Dr. Mesa in the past showing, strategies like meditation, relaxation, routine exercise. All of those have been found as well to improve patients' fatigue levels, quality of life. But we're still looking for the best form of therapy that, again, will improve symptoms but not offer too many side effects.
Wonderful. We'll take one last question, and that's posted up here in our Q&A box. Are the red blood cells smaller due to the ruxolitinib use, and does that affect the red blood cell count?
And so when we talk about ruxolitinib, it doesn't, it can lower the red cells. It's intended to lower our hemoglobin. So the portion within our red cells and the hematocrit, the thickness of concentration of the red cells. It doesn't necessarily influence the size. What we do know is hydroxyurea increases the size of red cells. And so when someone may be on hydroxyurea, they may have an elevated MCV level. And that would be characteristic of a side effect that patients experience with hydroxyurea. It doesn't influence or have a negative effect. But then if someone were to go from hydroxyurea and to stop that, their red cells will get smaller, as well as if they then get switched to ruxolitinib.
Wonderful. Thank you. I know we didn't get to everybody's questions, but I do want to say thank you so much, Dr. Cerquozzi, for your time and answering the questions that we did have you answer. Your expertise is very valuable for our blood cancer community. At this time, we'd also like to thank Forest Therapeutics, Pharma Essentia, and GSK for their support in making this event possible. And please remember that we are here for you. You can reach us by email, by visiting our website, bloodcancers.ca, or by calling us toll free. And please note that a short survey will be sent to all of our participants after this presentation. Please take a moment to respond as it helps us plan future events. And we appreciate everyone being here with us today. Thank you so much and take care.
Thank you.